Welcome to AFMC TV. I'm Robin Linder.
The goal of that is to maximize people's quality of life, right?
You want to make sure that your housing is affordable in your community.
We have to think about vaccines in a way that we haven't thought about them before.
I had a lot of the legislative adults who were very creative.
Down on the floor and play with their kids.
AFMC TV, thanks for watching and have a great day. Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Brendon McDermott. He's the Department Chair of Health, Human Performance, and Recreation and Director of the Heat and Hydration Optimization Lab at the University of Arkansas. Dr. McDermott, thanks so much for being here.
Absolutely. Thank you for having me.
So we're talking about the summer temperatures climbing and the risk of heat-related illnesses. Tell us about your research and how that's really helped shape national guidelines for recognizing and treating exertional heat illness.
So, and in our lab, we focus on preventive strategies for heat illness, focusing on thermoregulation, what can aid people in thermoregulation, what can really help people, ways to prevent heat illness, heat acclimatization, a whole host of things. And then we also focus a little bit more as well on managing heat illness once they occur, because we also know that not all heat illness is preventable. When we have exercise and we have very high temperatures and or humidity and stressful environments, we're going to have heat illness. So maximizing the outcomes following heat illness is also very important.
So how has our understanding of heat stroke changed over, say, the past decade? And what do healthcare providers need to know today that they may not have learned in training?
So interestingly, there were guidelines published in the early 2000s that focused on recognition and management of at least exertional heat stroke and having standard guidelines for acute recognition and cooling individuals or patients as quickly as possible that maximize outcomes. So not much has changed on that front, but our knowledge and use of those guidelines has drastically changed in the exertional space. I would also say when in training, there are some individuals where classic heat stroke was always seen to be a little bit different than exertional heat stroke, in that classic heat stroke individuals' thermoregulatory center will shut down and they will stop thermoregulating, and therefore they may have hot, dry skin. And we don't want to cool an 80-year-old who's been in non-air conditioned spaces and may have concomitant conditions very quickly because it may put them into cardiovascular shock. Things that we're kind of finding with recent research and recent management in certain big cities, San Antonio and Phoenix being two that I know very well, they've managed classic heat stroke much the same as exertional heat stroke management with very good success the past few years. And they are implementing partial cold water immersion for their patients on the way on transport and or implementing that in the emergency rooms, which has led to drastic increases in their outcomes and great prevention of death from heat strokes.
So when you say cold water, your recent study examined cold IV fluids. Is that what you mean? And what did you learn?
So no, we do the recommended practice is to cool people as quickly as you can. And we know that this is well documented in many studies where cold water immersion is what we want to do with our patient. And that can be implemented a number of ways. The recent study that we've done, and we've done a host of studies here looking at ice sheeting that is used in the military and cold IV administration. We did the cold IV study simply because EMTs were asking me about cold IVs because they've done this and had success with heat patients in ambulances on transport. And what we found was that, so we do studies here sometimes in our environmental chamber where we can control the environment. That was actually a field study where we took people outside and had them do repeated sprints until their core temperature was at least 103 degrees Fahrenheit. And then we cooled them down. So one day they lay in the shade. The other day they got a cold IV. And what we found is that the cooling rates were body temperature reduction in both of those trials was pretty much identical. So cold IVs in isolation as a treatment for heat stroke is not warranted because the cooling rates wouldn't do much to cool core body temperature down.
And Your team has also studied gaps in clinicians' knowledge about treating exertional heat stroke. What do you think healthcare providers still need more education?
I think the biggest thing is if we can recognize and manage heat stroke, classic or exertional heat stroke, quickly, and therefore recognize. So when we recognize and diagnose with a core body temperature, the only way to get, unfortunately, only way when people are really hot or exposed to extreme heat environments, the only way to get a valid core temperature measurement is rectally currently, unfortunately. So that's one thing. If we recognize that their core temperature via rectal means is above 105, their cells are cooking and they're going to have organ failure and organ damage as a result of their heat stroke. That means that their life-saving treatment is to cool them down as quickly as we can. And again, the gold standard for that is whole body or partial body cold water immersion, and with the coldest water possible and with more water. This is not the most feasible, but these are the things that I would love it if everybody knew so that we could implement these things as quickly as possible. We would have much better outcomes following heat stroke.
And are there misconceptions that could delay life-saving treatment?
So the misconceptions really are upon recognition. A lot of EMTs may not have been trained that once somebody's been exercising in the heat or exposed to a hot environment, that we can get a valid core temperature measurement via, the infrared scanners that we have, or ear temperature or oral thermometry. And literally those are not really responsive when it comes to anybody who's been exposed to extreme heat for a longer period of time or exercise. So that's one misconception, and it can lead to a misdiagnosis. So we take an oral temperature and it reads 101 degrees Fahrenheit. Core temperature might be 108 degrees. And that's the misconception. It's going to lead or delay the most valuable treatment for them. Again, their life-saving treatment is going to be to cool them down as quickly as we possibly can. That's the other misconception that for me, I would love to get out there, is that, cooling people down is their life-saving treatment. If we diagnose and recognize appropriately a heat stroke is happening, in order to save cells and therefore organs and prevent death and lead to much better outcome, preventing sequelae from their episode of heat stroke, is going to be to cool them as quickly as we possibly can.
And Arkansas has thousands of athletes, agricultural workers, construction crews. I mean, it goes on that work in the heat every summer. Which population concern you the most, and what makes them especially vulnerable?
So most often the athletes may be the most well protected. We know the most about them, and we have guidelines for heat acclimatization, and there's mandates, and if we follow, and there's WBGT guidelines. So once the environmental stress gets beyond a certain point, there's mandated hydration and rest breaks that we have, and work to rest ratios. All too often, the athletic population makes up a small percentage of those exposed to the heat on a regular day. There's the workforce is drastically probably underprepared for this. They're not acclimatized. It's not a focus and a culture at work to have water breaks, and they don't have people running around asking if they want to squirt for more hydration. And I would also give a plug to that sometimes the ergonomic safety folks are following OSHA guidelines, which ultimately are not that protective for the worker. So inherent heat exposure on a daily basis and doing sometimes heavy work is going to predispose us big time to exertional heat illness. The number one predictor of how high core temperature gets on a day is how hard people are working. So the more muscle contraction that people do, whether that's working on the farm, working in a plant or an industry, delivering packages on your day, if you're working hard, you're producing heat, and therefore you're storing the heat. And when the environment is hot, it won't let us get rid of the heat. And so the number one predictor is how hard we're working. So if we work really hard, there's a great chance that we're going to have a heat illness, or there's going to be people on the crew that are going to have a heat illness. So those are the individuals that worry me the most, that have kind of a lack of protection for them, and they're not really taken care of, but they're doing pretty heavy work.
And you touched on this a little bit about how heat illness is really viewed often as an athletic issue, but it's a much broader public health concern. So how should hospitals, clinics, EMS agencies, communities prepare for more frequent periods of extreme heat?
So again, when National Weather Service is putting out recommendations and saying, hey, we're predicting X, Y, and Z in terms of heat stress, that's the time to make sure that the healthcare professionals, okay, so EMTs are the ones on the ground and the first responders, to make sure that we're recognizing heat as heat illness, right? So if there's been extreme heat and we're getting the symptoms, or somebody collapses or what have you, or there's large groups of people. This is another scenario that's kind of dangerous, where we have, crowds of individuals at, World Cup watch parties or sporting events, or in the summertime, it's parks and big events that are happening at parks, is to make sure that EMTs are, whether they're on site or going to be called to these places likely, because not everybody's going to take care of themselves and heed the original advice that they got in the primary care office, right? So when they're dehydrated and predisposed and they have a heat illness, we need to recognize it appropriately. So when EMTs show up, they need to be recognizing that it's a heat illness and managing it appropriately by implementing all the cooling modality that they can, either on site or on transport. And then also the ERs to be prepared for that as well, so that when EMTs are transferring care into the emergency rooms, that they are also recognizing whether it's further recognition with the suitable diagnostics that they may have available to them in advanced care, as opposed to an ambulance, but also the cooling modalities present. And we found this too with one of the recent studies that we did documenting the cooling rates with doing partial immersion while a patient is in a body bag, because cities like San Antonio, Phoenix have implemented this as part of their heat illness management strategy with great success. So they're implementing these on transport with EMS. So if they recognize a core temperature that is potentially pathologic, then they're implementing and putting in at least 5 gallons of ice cold water in a body bag with the patient so that they're being cooled on transport. But body bags are also available in emergency rooms. So this is another scenario where if we can get a means of having ice water to cool patients immediately upon arrival and recognition, we would be leading to better outcomes down the road as well.
And your research has implications far beyond Arkansas, including for sports medicine, emergency management, medicine, and occupational health. How is the work being done at the University of Arkansas helping improve healthcare practices across the country?
Well, we hope people are reading our literature, and after we publish studies that there's an audience. But we've worked with in industry, and we've worked with different athletic venues to maximize strategies for recognition and treatment, following the prevention that we may do as well. So, we've helped with the National Athletic Trainers Association, and we've helped publish studies in emergency management journals to make sure that the audience is there for emergency rooms and EMTs, where we're setting the guidelines. And then I've also participated in consensus and position statement document writing, where we're establishing a standard, and then healthcare professionals can work together across lines and across boundaries to make sure that everybody's on the same page when it comes to managing a patient. So from the first responder to an EMT to the emergency room, and even prevention methods with primary care doctors as well.
So before we go, if you could give every viewer one piece of advice before spending time outdoors this summer, what would it be?
In order to stay cool, it'd be follow grandma's advice, really. Make sure you stay hydrated. Make sure you get a good night's sleep. Make sure if you're not feeling up to it, call it off. And when you're outside in the heat, take it easy. Don't overdo it. Again, the number one predictor of how hot your core temperature is going to get when you're exposed to heat stress is how hard you work. So if you do too much exercise, maybe the lawn can wait till tomorrow. Or maybe there's a cold tub waiting for you somewhere so you can cool down in between, just to make sure that you have those things.
Keep those ice packs handy.
That's right.
Well, Dr. McDermott, thank you so much for sharing your expertise and helping us better understand the importance of preventing and recognizing heat-related illnesses, and also just providing valuable guidance for our healthcare providers. Thanks so much for being here.
Absolutely. Thank you for having me.
And that's it for this episode of AFMC TV. Have a great day, and thanks for watching.